happy to see everybody on the phone, and or on the WebEx. And we wanted to just welcome everybody. I know that we had been talking about the ASAM continuum and being able to roll this out and implement this across the state. And we had a demonstration planned in April, and then because of the COVID-19 emergency, you know, that's become our priority. So we did want to follow up, and fortunately, we are so happy that Dr. Gasfriend is here from ASAM and Bill Liu from ASAM, and then Sarah Moore from FEI Systems. And so we will go ahead and hand it off to them for the demonstration, and then we can look at next steps after the meeting. So welcome, Dr. Gasfriend, Bill, and Sarah, and I am going to go ahead and turn it over to you to go through the ASAM Continuum demonstration and the screening tool.
Great. Are you hearing me okay?
Yes, we can hear you. Yes.
Terrific. And let's see if we can share my screen.
Yep, go up to the top left-hand corner and go share. Perfect.
Got it?
You can see your screen.
Welcome everybody. I'm David Gasfriend. I'm an addiction psychiatrist, and I'm the chief architect of the ASAM Continuum system. And I've been working on this for more than 25, 27 years now. It's undergone a lot of development, validation, experience in different settings, and it's constantly improving and evolving. And so it's not a fixed tool that researchers created for researchers that is imposed on clinicians. It was actually developed by clinicians. I'm a clinician at heart who recruited researchers and programmers to develop a tool for clinicians. And ASAM has invested heavily in quality improvement and the feature set that clinicians in different parts of the country, different settings with different patient populations tend to need. So you're going to see that clinical focus reflected in a whole bunch of different ways. So if you're seeing my screen, you'll see that the left side of the screen is a blue panel, and this is the navigation panel. And it has listed a whole bunch of sections: general information, medical, employment, drug, alcohol, legal, family, social, psych. And these are easily switchable. That's why it's the navigation panel. So unlike a research instrument where you have to go one by one through every section that the researchers developed, if you interview the patient and you sit down with them and say, tell me why you're here, and they say, well, it was the judge, and I would go to prison if I don't do this treatment, and I hate treatment, but I'm going to do it because they make me, and it all started when I got arrested, and that was for the heroin, but it was because of the doctors and their pills. The last thing you want to do as a clinician is interrupt the patient and say, well, be that as it may, I need to start by asking you, how long have you lived at your current address? So you don't want to interrupt an assessment. Instead, what you want to do is continue with the patient's lead. So I would skip in my navigation panel to legal information, and I would let the patient talk. I'm not even going to ask questions. And I'm going to hear that, yes, this admission or visit was prompted or suggested by the criminal justice system. So I'm going to click yes. And what factors might help you stay in treatment? Now, I've done a dozen or two of these assessments before, let's say. So I know what the question is. It's, how would any of the following help persuade you to participate in treatment? Relatives, friends, job, caregivers, or the law? And I know, because I've used this a bunch of times, that my patient basically just told me he's only in treatment by coercion. He's not resentful and wishes to reject treatment despite coercion, because he wants whatever benefits the coerced treatment will bring, like staying out of jail. So I'm going to click only in treatment by coercion. But I never even had to ask the question. And he'll tell me a lot more. And I'll just click through, and while I'm looking at him, I'll glance and click through question after question after question. And when he jumps to drug and alcohol about how he got into his heroin, I'll navigate in the navigation window to use substances. What substances has he used? And I'll click heroin, but he told me about pills too, right? So I'll click opioid or narcotic other than heroin, methadone, or buprenorphine, even if by prescription. So this gives me the ability to jump around, put in the information I need, and meanwhile I can see I have a bunch of areas that aren't being requested here, and that aren't filled in yet, because they're 0% complete. But as I get more and more through this interview, these will start reaching 100%, and I'll see the green check marks for entire sections that are complete. And at the end, I'll be able to say, you've told me so much about your problems and your situation, and that's actually going to be really helpful in planning your treatment. I just have a few other things I want to make sure I cover to make sure I don't miss anything important. And by the way, isn't that what you would do normally in a clinical interview if there was no computer? So what we've done is we've given you an interface that allows you to navigate in your assessment of your patient in the same clinical approach, flexible, meeting the patient where they're at, jumping around, remembering things, not in your head so much, but by documenting them into the answer set and having all this data recorded. So in addition to this left side navigation panel, we have the right side interview panel, which is in white background. And this has a bunch of questions that are marked by an icon on the left, and they're in a certain font. There's basically two fonts. There's italics and in quotes. These are questions that you want to ask the patient, or you want to have the patient's answer if they've actually volunteered it already. And you don't have to ask these verbatim. You can ask them in a paraphrased fashion. You could paraphrase every single question. So the language you like to use, the cultural adaptations that a patient might be comfortable with. You can ask them slower, you can ask them faster. And these two little icons indicate it's a dialogue question. You're going to pose the question to the patient, you're going to listen for the patient's answer. You'll also notice that most of the questions have a little I button. These blue I buttons are hints, information. And it says, if the patient has used many substances, clicking multiple categories will result in many repetitive questions. I don't know why Siri is responding here. So that information button tells us we can streamline. And this is a fairly recent addition that was requested by end users, interviewers. And ASM went to work in figuring out how to provide this to you guys. So it says to streamline, probe the patient to determine which substance or substances is most problematic. You may click the categories of highest priority need, but enter all substances used in the comment box for the benefit of providers who will receive the patient for treatment. So if the patient says, I've used every drug under the sun, and some you've never heard of, that's okay. I don't have to click all of these, because if I do that, I'll have to answer questions about all the DSM-5 criteria for every single one of these, and all the withdrawal questions for everyone that could have a withdrawal. And that'll be, a 3-hour interview. And that's not fair to the patient. You wouldn't do that clinically. So don't do it with Continuum. Instead, if you hear, well, it's really heroin and fentanyl caused the other opioids that were by prescription that they started with and became abusing of, well, that's history, because the only recent substance use is the heroin and fentanyl. But we'll put in the comment box that the patient started on prescribed OxyContin from their doctor for their back pain, and they no longer use that because it didn't hold them. So now we'll only have to answer the DSM-5 criteria questions for heroin use disorder. And they might say that they use benzos when they can't get heroin, but they haven't used any, at least in the past few weeks. So we don't have to worry about a benzo withdrawal. So I don't have to click this and go through the benzo withdrawal questions. I can just put that when they can't obtain heroin, they use benzos, but none in several weeks. So just like we would focus on things in a clinical interview, we get to use the Continuum questions and data set in a similar fashion. Now, if we were to go through this initially, section by section, you'll see that there are some interesting options. One option in the general information section in the beginning is that we can say that the interview was conducted in a couple different ways. It could be a phone or telehealth interview. This is new. And we offered this because of criminal justice systems like California's prison system, where they do remote interviewing. But it turns out it's really helpful for COVID when programs aren't necessarily seeing people in person. So you can do this by phone or audio telehealth, or you can do a telehealth video. And you click here to indicate that that's how the interview happened. That's useful because we may not be able to do all of the examination, let's say of the patient's tremor or their blood pressure, in the same way that we would have if it was in person. Instead, we might end up asking the patient to describe their tremor or their goose flesh or their sweats. Maybe we can't see it that well in the camera, or it's a telephone interview. So we'll have those options now in Continuum, and you can do remote telehealth interviewing. And when the calculations have to be made about the level of care, if you've had less information, some of the questions maybe aren't applicable because you're using telehealth, you'll be able to indicate that, and the computer will take that into account in calculating the level of care. And then when the report comes out at the end, it'll say that maybe this was a telehealth video and maybe the information may not be as complete as if it was in person, and therefore you have to take into account that that could affect the level of care placement recommendation. So we'll go through these different questions, and some of them you're not asking the patient, they're observations or just notations. So here there's not two little icons of people, there's only one. And it's not in quotes, special interview circumstances, and it's not in italics because this is just an observation. So the interview circumstances could include terminated, or the patient refused, or the patient is too intoxicated, maybe unable to respond. And the information button says, select none for routine interviews. So you can see these different types of questions, and you may also notice on the screen, some of them have a white background or just a normal background, and some of them have a yellowish greenish highlighted background. And that yellowish greenish highlighted background means it's a required question. In order to score and get a level of care, you've got to answer all of these highlighted questions in order for the computer to be able to calculate the algorithm. You'll also notice a controlled environment capability here. There are patients who are in a reentry state where they've been in jail or prison and they're getting ready for discharge. Or they could have been in psychiatric inpatient treatment or medical hospitalization. And that'll affect a bunch of things. For instance, their access to drugs, or whether they've been with family or the social environment that may have been triggering, or maybe they were removed from that, but when they re-enter the environment, they'll be back in that environment where they were triggered before, and we'll have to anticipate, will those pose challenges that will need more structure in their treatment? And so you'll see questions in here that address controlled environment possibility so that the algorithm can take those things into account. I'll say more about that at the end when we talk about reentry and anticipating needs as a discharge occurs. When you finish a section, you'll be able to move by tab or by clicking the next button, section by section, and you'll see extensive medical history questions, and you'll be prompted to ask questions even if you are not trained medically or in nursing, and they'll be rich enough, detailed enough, that you'll be able to detect medical risks even if it's not an area of your own expertise. So the patient will know if they've had these problems, and they'll tell you yes or no. And sometimes you'll have a not sure, or possibly. And you won't know, well, like, would that trip them up into a medical placement like a level 4 or a bio requirement, biomedically enhanced care? And you'll click on the information button if you're not sure to see, oh, well, this is pretty serious stuff, seizures, cardiac or diabetic conditions. So you'll get a little bit more background. And we're always improving these hints. So as you use the instrument, if you find, something wasn't clear to me, or something led to a placement that I thought was really incorrect, if you can figure out there was a question that you didn't really understand how to answer and you think you might have answered it in a way that was misleading, you'll be able to tell us what number question this was. You'll be able to email and say, on question B.A.0170, I had a problem answering that, and I didn't get enough information on the hint to know what to do. And we will analyze that and figure out, oh, maybe we could add another sentence to explain that would make that more intelligible. We're doing that all the time. So this is where you're not just working for the Continuum database. The Continuum developers are also working for you. And many, many of these improvements have been the result of your colleagues who are doing these interviews. When it gets to the drug and alcohol section, there are some very important clinical tools. So for instance, the withdrawal assessment, that's sometimes a difficult thing to assess, and it requires some nursing skill or having worked in a detox normally. And not everybody has had that experience. So we decided to take a research quality instrument, and in this case, we use the CINA for opioids or the CIWA for alcohol. These are validated research instruments. And we provide them to you on the screen, so you don't have to remember all the questions that need to be asked. You'll get prompted to ask them just by the computer. And you'll be given English language phrases to ask, not medicalese. So for nausea and vomiting, the prompt is to ask the patient, do you feel sick to your stomach? Have you vomited recently? And if you want to say thrown up, say thrown up. If you want to say nauseous, you don't have to say sick to your stomach. It breaks this into two questions, but if you want to say, do you feel nauseous or have you vomited? You can paraphrase it that way. And if you're not sure about what does recently mean, you can click on or hover on the information button, and it says time frame is now, during this part of the day. Because if it happened during the night and I'm not having that anymore, well, then it's not as acute and might not require detox or as much detox medication at this point. Also, you'll notice that although sometimes you'll see a numerical scale, we don't require you to memorize what's a 9 versus what's a 0. We almost always provide English language phrases that capture the distinctions in the different parts of the scale. And when we separate the different parts of the scale with these distinctions, that's also how the scoring takes advantage of the numbers. So even though there's nothing here for 4 or 8 or 9, it doesn't matter, because if you have a 5 or worse, we're going to use that scoring in a similar fashion. So it'll tell you, well, 0 is no nausea and no vomiting. 1 is mild nausea, but no vomiting. 2 is dry heaves, but no vomiting. And 5 is nausea, frequent dry heaves, and vomiting. So this is spelled out so that even without a background in nursing or detox, each of these is intelligible. You can understand it and figure out, how do I use the best answer? In the drug consequences question, there are very specific items, and some of them are required, not the first one, but the second, third, and fourth questions on this interview screen. And when you need to round off, you can round off. You don't have to do exact, precise answers, just like you would do clinically. And you'll see sometimes there's a color scheme where green represents the go, safe, easy, least intensive end of the scale. Amber is in the middle, just like a traffic light, and red is stop, dangerous, most extreme. And we'll always use that color scheme so that you always know, it's obvious what way the scale is intended. When you've had prior treatment, we're going to ask more questions. So you notice it's branching. There's a lot of branching, and that means it's personalized, it's individualized, it's patient-centered. And we'll not just ask, have you ever been treated for drug problems? Maybe you've been treated 10 times. But that doesn't tell us whether you've had adequate treatment or complete treatment. So it'll probe for, well, counting the times in your life you've been treated for drug use problems, how many of these were for withdrawal management only? Now, that's the technical term, withdrawal management. If you want to substitute detox, because that's what your patient will understand, you're supposed to go ahead and substitute detox. So the patient says, yeah, well, all 10 times I was treated, I was in detox. Okay. Have you usually left detox before you were supposed to in the past? Yeah, they didn't give me enough meds. I got antsy in there. I never stayed. I never finished it. And after detox, did you usually go into continued treatment? No, I know they wanted me to do that. I never did that. Okay. So now we've really captured that this patient hasn't had a comprehensive treatment before, a longitudinal course of care. And if they're really motivated to get treatment now, we're in a better position to argue to managed care that this time the patient should really be covered for a full admission, for detox, followed by rehab, because maybe their motivation is in a different place or there's more coercion, and the likelihood of a success is better. This is not just a revolving door readmission. And there are ways we're going to learn about that motivation and that trajectory. So first we're going to ask about craving and potential for continued use, because as you know, relapse and continued use potential is dimension 5 of the ASAM criteria. So it's a very important dimension. And craving is also part of the DSM-5 criteria now. So we're going to have a question that isn't just, are you craving? The patient may be sitting in your office for an hour or two in a clinic where there's no access to drugs, and the brain may shut off the hunt response for drugs, and they may not crave. So we've got to operationalize this. We've got to put this into a perspective that can work to assess craving. So we're going to ask a question sort of in these words. Imagine you're in the place where you were using your heroin. If you're there today, what's the likelihood that you're going to use? Now you notice I paraphrased every part of this. That's fine. So the patient says, oh, if I'm back, if I go back to home where people are dealing and they know where to find me and they know I want to get stuff every day, that I'm definitely going to use today. Okay. So rate for me how strong your urge for heroin is when something back home reminds you of it. Oh, if I see the guy who gets me my stuff, it's like I'm running over to him. Okay. Now, I don't have to say, well, tell me, is it slightly, moderately, considerably, or extremely? I can gauge that for myself based on what the patient just told me. Now, I've had the patient think about what happens in their environment, what happens when something reminds them of their use. So now if I say, how strong is your urge to use heroin right now? The patient will say, oh, well, it's there. It's not the worst it could be. It's not terrible. I can hold on, but it's definitely there. So I might click moderately here. And now we've really captured this. Now, I don't want to know just now how it is. I want to know, how about recently? How's it been going? And I'll ask, have your addiction symptoms gotten worse lately? Now, sometimes the patient will just say, but there's not a lot of clinical detail there. So I'll say, well, how? It's an open-ended question. That's what the ... means. And the patient will say, I don't know, I can just tell it's getting worse and worse. So the instruction is ask about any items below not mentioned by the patient. So I'll ask, well, how about, have you had more craving lately? And the patient might say, yeah, I'm craving all the time. It used to be I'd use when I had pain and then it'd go away. Now, every day. All right, have you had more risk behaviors? Well, I'm going to that part of town where, I've gotten robbed a couple times and beaten up. I know it's crazy. I can't help myself. Have you had more frequent use? Well, yeah, I'm using every day. I used to just use like a couple times a week. And are you using more or using it in a faster way of getting it? Well, I switched from the pills, like I said, to the heroin because it really hits me. And I kind of need that. So I have a bunch of options here. I'm not going to read this to the patient. I'm going to read this to myself. And once I've done this, 15, 20 times, I remember what's in here. And the answer is, it's definitely not no. It's not just increased craving. It's not just more risk-taking behaviors, but not use. It's not just that the patient has relapsed to less use than before. The patient is increasing his use and has a more acute route of administration than before. So this is clearly the closest option for me to click on. And it's like that throughout here. Very clinical, very common sense. I want to find out about motivation. That's dimension 4 of the ASM criteria, readiness. So I've got a set of questions here, and it goes from an open-ended question. Do you have any concerns about pursuing treatment? And I could stop there, or I could go on. If I stop there, the patient might say, no, I know, I got to do treatment, no choice. But then I might want to probe, well, would anything possibly hold you back, like money? Oh no, I don't have any money. They laid me off from work because of my addiction. I can't spend any money. All right, how about insurance? I don't know, I might have insurance still. I don't want you to use my insurance because I don't want them to know that stuff gets back to work. How about the schedule? Is the schedule a problem for you? Well, I'm going to try and get day labor while I'm laid off, but if you have something on the weekends, maybe I could do that. How about attending groups? Are you okay with attending groups? Oh, and I don't want to talk about my stuff in front of other people. People are nosy. How about having to take medicines? And I've literally had patients say to me, oh no, doc, I'm all natural. So, and then drug tests. Are you okay if we do drug tests? And some patients will say, well, wait a minute, I'm here voluntary. I don't want you telling the courts anything. I don't want to take any drug tests. And how about, are drug using friends any kind of a concern? And people will say to me, Well, what do you want me to do? You want me to get new friends? Well, who wants to be friends with me except somebody who's using drugs? So now I have rich clinical information about motivation. And I can score this readiness. This is not somebody who's open to all recommended treatments or already doing them. It's not somebody who's just passive or who's just ambivalent about important responses. This patient I portrayed is rejecting or obstructing the plan with many contingencies. So I'm going to click that as the closest response to what the patient has told me. And then there are many other ways we can get at motivation. And we can operationalize that in terms of how they plan to prevent relapses if they've thought about that. So lots of very clinically oriented questions, and they're really designed to help you do what you normally would do. The more skilled you are, the more experienced, the more you can paraphrase and tailor the way you ask these questions to get the patient most comfortable and help them provide the best information. Now you notice at the bottom here, something popped up. I tried to switch to another section, but it says you missed 3 fields. They have been highlighted. So I can actually go to those and I'll see where I need to fill in. Oh, I had put in cannabis and I didn't answer some more information about this. And there's an error. I wrote that they used fairly recently, but it says the last period of abstinence doesn't fit with that. It conflicts. So this is some error checking that gets built into the instrument. And I guess I'll fix this. This is because I've changed things in here, so. All right. This is good. It's not letting me do this. I might have to go back. And this is because I'm using a page who's already been filled out. So I'll leave this and open a different patient. In the legal information section, okay, I did sign in. Let me do that. This is a security thing that if it's too long, it makes you sign in again. All right, so I'm going to select my patient again. And I want to go to, interesting. Let me see if it'll let me jump. Okay, we have a bug. So I'll ask the FEI folks to work on that. Let me go to a different section. In the family, I can show you the same thing I wanted to show you. In the family history section, there are some questions that involve groups of people. So for instance, well, have you had significant periods in your life where you've had serious problems? I could ask each one of these separately, but that would take a longer period of time. And they're all grouped in a box. So in training, what we teach the interviewers is group these together. And you can say, as long as it's a patient who's got good comprehension and they can track what you're doing, and by now you know how the patient is with it or not. So I can say, have you had a significant period in your lifetime where you've had serious problems with your mom or dad, your siblings, if I know they have children, your kids, your partner, or friends, coworkers, or other family members or neighbors. And the patient might say, well, my dad was the person in my life I had all this trouble with. And my mom was always great, and I'm an only child, so we can say not applicable. And we can click through this quickly as the patient keeps talking. Obviously, it takes getting used to this and comfortable with it. That's why it takes about 10, 15 cases to get really secure. But then you can really speed up the assessment. And you'll get into questions that are very important. For instance, trauma background is a critical thing in people with substance disorders. And we have a particular way of approaching the trauma question process. So after assessing who are the people you've been involved with, what are the conflicts you've had with them, we're going to very specifically ask about abuse. And we'll do this in a sequence that is ideally designed for comfort and minimizing patient emotional reactivity. So first we'll ask about emotional abuse in the past month or so. And then we'll ask, well, how about any physical abuse? And the most charged and emotionally laden question is, and you've told me about that, but I'd also like to know about any possible sexual abuse you've been through in the past month. And if you've been non-reactive and open and supportive, the patient becomes increasingly comfortable with the Helping Alliance. So you're going through all of the items you would in a biopsychosocial comprehensive assessment, and you want to cover even questions about your own risk of abusing others. Now, if you just ask somebody, are you prone to abusing others? They're going to say no. But if you balance the language with a less stressful term, like neglect, you may get an indication. So instead of saying, have you been abusing your family members? We ask, have you recently neglected or abused family members? And the patient might say, I don't know. My girl might say, yeah, maybe I neglect her. I don't know, maybe I do. And we even explain neglect means failure to provide necessities that may have or result in serious injury, illness, or death. Now, we don't know what the patient means there, and we may not get to probe that here. We can look for the information above. Recently means past 3 months. Use all available data. So if there's something in a chart that says yes, we're going to use those data to help draw the conclusion. It doesn't mean just not spending time with somebody or not being available. And if we're not sure, but the patient indicates there's something there, we might just click the minimal answer, mild or slightly, and then it tells us that there are things we have to consider. If it's abuse or neglect of a minor or elderly person or other vulnerable person, we want to be sure to address safety issues. There may be legal reporting requirements, and we even have some of the resources for accessing that. So we get some useful information on a critical item like this. And somehow my screen sharing is interacting with my ability to scroll down here. So I'm not able to jump out of this. So let me go back and reconnect. This will be quick. Zoom. Okay, because I want to show you another important section for assessing the comprehensive biopsychosocial. We need to assess the patient's psychological or emotional problems. That's dimension 3 of the ASAM criteria. And they may know that they have a disorder of some kind and be able to tell us that, which is great. But many people suffer from behavioral issues and they don't have a diagnosis for it. They haven't had care for it, and it's not clear whether it's related to their substance use or dependent. So we're going to do an inventory of psychological symptoms, and it leads off with, have you had a significant period in which you experienced serious depression, the blues, or hopelessness? And if we answered no, not at all, we're done with that question. So there's no branching if these are not problems. But if there is a problem, whether it's slightly or extremely, we want to know, is it current? So if we ask, have you had a period where you've been seriously depressed or had the blues or hopelessness, and the patient says, oh yeah, my whole life I've been like that. I'm like that today. At times it's been horrible. But it's middling right now, mostly because I'm just coming off of my heroin and I hate that feeling. Okay, so I know that this patient is not just a lifetime sufferer, but they've got it currently in the last 24 hours. And I can just click in these things. I don't have to ask each of these questions one at a time. That would be very tedious and slow. I mean, the first time you do this interview, maybe you have to read each of these items and think about it and ask. But by the time you've done 1 or 2 dozen, you want to speed up and do what you do clinically, which is make more efficient assessments. But you'll notice it just opened up this next question. Was this problem, which is depression, within the last 24 hours related to using drugs or alcohol? And the patient told me it's because they're in withdrawal, right? So it's not unrelated to use. It's not related to active use or intoxication. It's related to substance withdrawal. And it could also be unknown. The patient could not be sure. And it doesn't say definitely related, but likely related. So this is going to give the algorithm information for recommending either co-occurring capable services where they're going to watch the depression as the patient goes through withdrawal, keep an eye on it, and get a consultant in if they need more assessment. Or it may be that they have a lifelong serious depression, and when you add up all the depression symptoms and other risks, they really need co-occurring enhanced care where they can start administering psychiatric meds and modify the meds according to the patient's progress. You'll also notice that there's this big box here. This box includes serious depression. It goes down to lack of interests. It goes down to poor appetite or overeating, feeling bad about yourself, moving slowly. And what we're doing is seeing the grouping of neurovegetative symptoms of depression, a whole menu of depressive symptoms. If I wanted to group these all together, I could get more efficient. I could say, I'm wondering in your lifetime if you've had a significant period of depression, the blues, not having interest in things, or not getting pleasure, or not eating well, feeling bad about yourself, or even moving or speaking slowly compared to others. And the patient might say, oh yeah, I've had all of those things. I don't know about this moving slowly thing, but everything else, yeah, I've had it bad. And they've given me meds for that. Even when I wasn't using drugs, I've had that. So now I know all the questions to all the answers to all these questions, and the time frame and the relationship, which is independent of substances, and I can click through and answer these very efficiently. And we'll go through anxiety disorders and separately panic. We'll go through restlessness and ADHD type symptoms, insomnia. We'll go through intrusive, persistent anxiety and worry thoughts like obsessions, compulsions for repetitive behaviors, paranoia, delusions. And there are people who can say, yeah, I've got delusions. I know things are crazy, but I can't stop thinking them. hallucinations, and it breaks down. Hallucinations can be a variety: seeing, hearing, smelling, or even feeling, tactile hallucinations, which can be part of, for instance, alcohol withdrawal. Flashbacks and other trauma symptoms, cognitive impairments, irritability, trouble controlling violent behavior. These are access to issues, or just to fight or hurt other people, or damage property. And then we can get into the suicide questions. Now, there are many programs in the country that are not comfortable doing a suicide assessment. But really, they could if they had the right questions and the right scoring. So Continuum prompts even the novice interviewer, even a social work intern on his or her first day in the field placement, they can do an effective suicide assessment. So they'll ask, have you had, serious thoughts of suicide, that you'd be better off dead, or wanting to hurt yourself in your lifetime, or recently, or today? And the patient might say, well, yeah, I've had them. I've been suicidal, really bad. I mean, a little bit lately, and maybe now, but it's just because I need some meds. Okay. And is that usually because of withdrawal, or have you had that even when you weren't in withdrawal? Yeah, I've had it lots of times, even when I wasn't using. All right. So this patient may be at risk, and we have to probe this further. So we've asked about the thought of suicide itself. That's suicidal ideation, but we need to know about suicidal plan. Have you had thoughts about how you might hurt yourself? And if the patient says, well, I've got a gun, I know where the bullets are, right? It scares me sometimes. Okay. Have you made attempts on your life? Yeah, I've overdosed a couple times, and I knew I was doing it. I wanted to do it. And later we'll find out about safety and supervision, monitoring the environment, or whether that's lacking. The algorithm will put all this information together. It will decide whether there is a suicide risk, it's modest, and it's really related to withdrawal. So if it's going to recommend a withdrawal level of care, it will take into account that probably will ameliorate the suicide risk. But there may be a need for co-occurring capable monitoring. So the algorithm will take all this into account in scoring it, and you don't need that skill level. Later, when you get good at the interviewing and you want to learn more about how the logic works, you'll want to turn to the book. So that's a message I want to make sure I state now. The book and Continuum go hand in hand. The ASAM Criteria book, the 3rd edition, it's 500 pages long. We don't expect you to read it before you start Continuum, but we want you to have it in your clinic, in your program, accessible, so that once you're comfortable doing these assessments, after you've done a couple dozen people, you're going to want to understand, why did it pick this level and this qualifier of co-occurring, whatever? How did it come to that conclusion? And you'll look at the book and the decision rules in the book, and you'll say, oh, I remember they asked me a question exactly about that. And then you'll understand how the decision rules are taken from the book. Every single decision rule in the book for adult admission criteria is implemented with one or more questions in the Continuum assessment. It's quantitative, it's precise, and it's comprehensive. When you get to the end, I want to point out that we're going to ask questions about how the patient has responded. This is something you would do clinically. If you had a patient who came in really frazzled, and by the end of an hour's interview, this patient was really calmer, was connected, was able to talk a lot more about things in their life that's going wrong, and you could see our program could really help stabilize this person. Maybe they need to be here for half a day or a day treatment, get some meds, but this is the patient who could do well with this kind of support. Well, we have these questions. They're not in quotes or italics. There's not 2 people icons here. This is judgments. And so we're taking advantage of your experience and your intuition. Obviously, the more skilled you are, the better you'll answer these questions. But when Continuum or its predecessor was used in research, even with new counselors or brand new research assistants, it still got an excellent level of inter-rater reliability. That means standardization, because of the detail and sequence of the questions. By the time you get to this, you've asked a lot of different categories of information, 6 different dimensions. And so you're in a position to judge how likely the patient might be responding, or likely to be responding, to withdrawal management care if they need that. And all of these completion questions help refine if they're going to need withdrawal management, if that can be managed as an ambulatory or intensive ambulatory case. You'll get to say what you think acceptable levels of care would be for the patient's mental status and ability to participate. So we are taking your judgment into account. And when we analyze the placements in thousands, tens of thousands of placements, which we are doing nowadays, we actually look at, well, what did the clinicians think would be optimal or acceptable versus what did Continuum's answers say? And we find discrepancies, and we analyze those to continually improve the algorithm's performance. So we also ask the patient. This is a two-person icon question in quotes and italics. And we say, are there any particular treatment settings that you wouldn't accept, that you would think, aren't right or you won't be willing to do? And the patient might say, well, I'm not going to one of those halfway houses where they make you scrub the toilets with a toothbrush. I've been through that, and I hate that. I fought them, and I left. And it made me worse. Okay. Or I won't go to a hospital. They nearly killed me the last time I went to the hospital. If you send me there, I'm going to run out. So we'll indicate what are unacceptable levels for the patient. That doesn't mean we won't recommend them if that's really the right thing. And it might mean that there's more motivational enhancement work that needs to be done. But we are tracking that. And so we get through a bunch of these answers. And when you save, and if you've answered all of the questions in all of the subsections, and there are green check marks all along, you are ready not just to save, but you'll see a button here to submit. And you'll submit, and you'll see popping up on the screen what level of care is recommended by the algorithm. And it could be actually a mix of things. Some people are on the gray zone between a couple levels of care. And even qualifiers, occurring enhanced, biomedically enhanced, withdrawal management. ASAM says you can get a level of care for your rehab needs, and you can also get a recommendation for opioid treatment services like MAT, medication and assisted in addiction treatment, like methadone, buprenorphine, or extended naltrexone. And so you'll get those recommendations in a pop-up window, and then you'll talk with the patient about what's recommended and see what the patient will accept and what you think is appropriate. So you'll click in what you and the patient are willing to accept or prepared to go forth with and place the patient in. And it'll ask you to indicate what that is, and if you disagree, why you disagree. I'll show you that in a moment. Once you put that information in, you can print out the report. Now let me drag this report over, and hopefully you'll see that. And I'll expand it. And we'll finish up the tour very shortly because I want to leave time for your questions. So this is the summary report, and it starts off with psychiatric conditions that could impact the whole interview. This patient indicated possibility of suffering from a major depressive disorder. It doesn't do formal psychiatric diagnosis, but it'll indicate likely areas of concern. It does do DSM-5 substance use active diagnosis. It'll say which drugs have a substance use disorder, how many criteria out of the 11 DSM-5 criteria are met, and whether that means it's severe, moderate, or mild, most recent use, and whether there is imminent risk of withdrawal for that substance. If the patient has drug use but hasn't met criteria, it'll list that here. It'll indicate withdrawal scores, if there is any withdrawal, the addiction severity index composite scores for all 7 of the subscales. It'll give you the numbers as well as a chart. You can see this patient has serious, this is a different patient, by the way. I just wanted to pull a printed out scored version. So this patient had a lot of alcohol and some psych stuff that was really active and several other areas of concern. Critical items like potential harm to self or uncontrolled violent behavior will be listed, suicidality. It'll go through a dimension by dimension review of whether each dimension has particular levels of care that could be eligible. And it will even show a grid of that. But we suggest that you don't pay attention to this until you've used this several dozen times with patients and you're really efficient and comfortable with the interview, because this is another stage of understanding and it requires the book. You don't just add up, well, which level of care has the most pluses? That's not how the ASAM criteria works. Your decision rules are more intricate. It'll cover access to treatment issues. This is very critical in terms of whether the patient can tolerate outpatient or requires residential treatment services, and the final level of care recommendations. And these can be sophisticated, like a true clinical consideration. If it was a research tool, you'd get a score, 67, and you'd know what that means. But it's not a research tool, and patients don't fit into simple research buckets. So it says the patient could be considered, right? That could be, for treatment in a level 2.5 and 3.1. That's a combined program where you have 2 different sites that are maybe in close proximity, and in the day the patient's in intensive outpatient treatment, or partial hospital actually, and 3.1, a halfway house where patients are out during the daytime, most are working. But if the patient's going to get 2.5 care, they would be best initially treated with co-occurring enhanced. So it sounds like they've got mental health needs that need to be pretty actively consulted on. Medications have to be started or modified. If the patient is best initially treated in level 3.7, that's more intensive than the 2.5, 3.1 combo. It's a little bit more intensive, and it has more innate mental health monitoring and dosing capabilities. So if that's the case, then they might not need co-occurring enhanced. They might do it adequately with co-occurring capable. And then it also tells us that the patient has met 1 or more dimensional criteria for opioid treatment services. So this patient has some, let's say, past use of opioids, that she's abused, but she's not currently dependent on them, and doesn't show signs of rapidly relapsing to opioids, because alcohol is the bigger risk for her. So she hasn't met final level criteria, but it cues us into keeping an eye on this in the treatment plan. So this is one of the reports. Now, there are some other reports. There's a biopsychosocial narrative, and that can be the printout that you put into the chart for the comprehensive biopsychosocial. General information, each of the main sections, medical, employment, alcohol and drug, and so forth. Then it goes into the patient's perception of problems and needs in each of these areas. Sometimes they might say, yeah, I know I have a problem, but I don't want to work on that now. I don't want to spend a lot of time on that now. And this will give you a clue to all of that. This also gives the ASI scores, which can be useful in treatment planning. And then it actually will print out a detailed problem list. So every positive finding that is in the Addiction Severity Index, which forms more than half of the questions of Continuum. That will print out in its ASAM dimension, 1 through 6, and it will guide you for what do you have to take into account and then focus on when you write up the treatment plan. So it's not a treatment plan per se, but it gives you the initial problem list for generating the treatment plan. So when we finish, we will go back into the interview and I'm going to go back to a patient who's been finished, who's had a complete interview. And I'm going to show you that you get to provide your own rating for why you disagreed. So you may have agreed, and your final disposition is the same as, or it's at least overlapping with what ASAM recommended, the summary report. But it could be a different treatment program selected because the patient refused what ASAM recommended, or it's unavailable, or there isn't any transportation to get there, or the patient has childcare responsibilities and can't go to inpatient or residential, or lacks insurance, or insurance won't approve, or the program has a wait list, or the patient rejects the program rejects the patient. There could be many reasons, including if you were the interviewer, maybe you disagree with what Continuum is recommending, and then we'll ask you to explain that. We use this information to fine-tune the decision rules. In fact, we even use this input from you to rewrite the ASAM criteria book itself. So there are a number of sections of the book that will be coming out in the future where they'll actually be changed from the current book based on empirical quantitative data from this kind of response in the database. So it is a two-way street. We are trying to assist you with a clinical tool. Yes, it's a computer. Yes, there are questions on the screen. Yes, it's quantitative data. But the way you use it is totally clinical in your relationship with the patient, how you get along, how you format questions, how you use all your observations, body language of the patient, their timing. Are they really thinking? Are the wheels turning in their head? That's something a computer can't sense, but you can. So we're going to use all of that, including your own disagreement with an answer. And we have been making terrific progress. Initially, there were a lot of patients who couldn't get an answer. That's changed. Now, 90% or more of patients, you get an answer, and it's often overlapping. We've found ways to speed up the interview. I only told you a little bit about that. There's many other ways to speed up, and the training will cover that. The interview has been revised for the reentry setting. So if you're seeing people who are getting released from jail or prison, and you have to think ahead to what's their environment going to be like in reentry, there's another version coming out that will be suited to that, where the questions will be phrased in a much more obvious way for the reentry cycle. So all of these are improvements that we're continually introducing month to month or every other month. So let me stop there, and I will ask for questions. And if somebody's monitoring the chat or the questions, I believe you've had...
Sorry, I was talking on mute. My apologies.
Good. Yeah, please tell me the chat questions because I don't see those.
Yep. Yeah, so the first one, is this expected to be done with outpatient clients only?
Oh, great question. No, new residential patients, new detox patients, all levels of care can utilize this. Now, If you have a seriously distressed withdrawing patient coming into detox, you don't want to do an hour-long assessment. You got to figure out what are the withdrawal needs, what are the medical needs, what drugs or alcohol use has been happening. And what you'll do is you'll fill in those sections, the medical history, the drug and alcohol section, and that's going to give you more than enough information to know how to start the patient. And then a couple days later, when they're much more stable, you can complete the assessment, and that will both justify the placement in detox, and if it's 5 days later, you can actually go back in, pull the data that you assessed 2 days ago forward into a new assessment, and now all the previous data is already in there. You only have to change answers for the items that are likely to have changed. So for instance, all the withdrawal scores will have changed because you've been treating withdrawal. So you'll reassess those and it'll show that the patient's withdrawal is substantially diminished. But their lifetime psych stuff and their whole history of drug use, none of that's changed. So you've got a very quick interview for the step-down determination. So that's the beauty of pulling the data forward and having all of this in a single database.
Thank you. The next question is, how long does the ASAM assessment take?
So the first time you go through this, if you just make a patient in your own head, it's going to take you an hour and a half to just read through all the questions and click through everything, maybe 2 hours. The first time you sit down with a patient, especially if you haven't practiced, it's going to take you a couple hours. And you're going to want to say to the patient, I'm new at this. This is a recent new technology that's supposed to be really helpful, but I want you to bear with me. And you want to say to the patient, tell me when you're starting to get tired, and we're going to take a break. But when UCLA independently analyzed how LA County clinicians and interviewers were doing with this, after they got trained, and after they got past about 18 patients interviewed, they found that it averaged 60 minutes to do this comprehensive assessment. And of course, the minute you finish, you've also produced the narrative report and the summary report, and there's no more documentation to do. So you've got all your documentation finished, as well as the biopsychosocial in that 60 minutes. If you don't get through a dozen or more cases, which those of you who've been using this either on the demo site or in production, none of you have gotten through that many. I know that because we actually pull the data, and so we see how many assessments a clinician has done. And so you're going to have, some assessments that are going to take a lot longer. And if you haven't had the training and learned how to streamline it, and you have a patient who's complex, multi-site problems, multi-substance, and you answer it in the most detailed way, it could take you 3 hours. And we don't want you to do that because you wouldn't do that clinically. So that's the answer. When you get skilled and you're trained, this should take you about an hour on average.
All right, so we have a lot of questions coming in the chat function, so I'm just trying to kind of review and reorganize. So the first one, can more than one clinician update the same assessment?
Yes. If you're in the same system, you'll each have your own password, but multiple clinicians can complete an assessment, and a different clinician can pull forward the old assessment and reassess the patient for follow-up any number of times. Yes.
And then the other one, has there been any work having non-clinical folks such as probation officers using this tool?
Yes, they may need more training and they will certainly need supervision, but absolutely. They'll need help understanding the ASAM criteria, for instance. You have to have a basic understanding of the whole model and things like, medication-assisted treatment, the use of meds in different levels of care, the fact that you can have outpatient detox. So there's a lot of things that have to be understood, but the questions are plain English. They're logical, common sense. So if they can do an assessment from a clinical perspective without a computer, they can do an even better assessment with the help of the computer.
Do you have any, I guess, information on how to keep a client engaged for out for an hour to 2 hours for an initial engagement session?
Yeah, it's a really good question. You would think that this is the easiest way to turn somebody off in the world. It's actually not what happens. How do we know? Well, because we ask these questions. How do you rate the quality of service you have received? Do you agree with the type of treatment? We actually have another question that's in there now. This is the demo site, so you don't see it. Would you recommend this to someone, to a friend in need of these services? And surprisingly, we get very high satisfaction ratings from patients. We actually ask also, what did you think of the length of the interview? Was it too short, too long, or just about right? Well, nobody thinks it was too short. But the vast majority of patients think that it was just about right. And the reason is they say that they get tired, but they say, boy, nobody asked me so many questions about my problems like you did ever before. And they like that. They feel that you're really paying attention. You're wanting to know them as well as it's possible to know them. So, and they sense the branching. They know that you're not just rattling off a checklist of things because you're stuck having to do this. So as soon as you sort of get your nose out of the computer and are back to looking at the patient, they feel like, well, this thing is okay.
Thank you. A couple more questions. Sorry, they're all over the place. We have a lot of questions about, just so everyone knows, I did receive your questions about the EHRs and having them linked. We'll follow up in a separate email on those, but we want to specifically any ASAM questions for Dr. Gasfriend. One is, can you bypass the detox section if they're transferring from detox to residential?
Yes, if you know that the patient does not have current withdrawal symptoms, you can check those off at the minimum and just click, click, click. It doesn't quite bypass, but if they haven't had use in a recent period of time, then it will bypass. So one way or another, you can minimize effort in that section.
All right, the next question is, what is the error rate for the recommendations?
That's a good question. We don't get information that way. In the research studies, what we did was we compared people who were matched to treatment according to the recommendations against people who were mismatched. And we looked at things like, well, different outcomes. So for instance, one study found that mismatched patients have dramatically higher dropout rates from just entering treatment. They won't go to treatment at a high rate. 30 days later, mismatched patients have worse global outcomes. 90 days later, significantly more patients who are mismatched to treatment have dropped out, and fewer are ready for step down. A year later, patients who didn't get matched treatment, who were more severe than the services that they got, were more likely to spend days in the hospital. So the research doesn't look at an error rate because you don't necessarily have a gold standard of perfection of what is the perfect accurate placement versus an erroneous placement. But in terms of the outcomes, there are multiple studies in different time frames, different populations, actually even in different countries and different languages that have consistently shown a positive signal that this placement, if done properly, matched to this treatment, is prone to getting a better outcome.
Thank you. The next question is the tool, are you able to complete or get the summary without all the sections being 100% complete?
No. You can get the summary reports without the unrequired questions, the non-required questions. And if you're pressed for time, that could be a strategy for streamlining. And we'll talk about that in training. But the highlighted questions all have to be answered. Now remember, that doesn't mean you had to ask all those questions. You have to have a clinical sense of what those answers are and plug them in order to score and get the recommendation.
Thank you. And then another one was, how is the data used by ASAM? Are you trending and how are you doing outcomes?
Yeah, that's a really good question, because the difference between this and your routine charting is not just comprehensiveness and standardized assessment and structuring the interviews. It's also, you've got data now, rich, quantitative clinical data. Now, ASAM actually doesn't get the name of your patient. We can't identify the patient. We don't get personally identifying information. That's a HIPAA protection for your program and your patients. But we get the de-identified data. We analyze completion rates. If it's too long, you'd have high non-completion rates. We don't have that. We have low non-completion rates. We analyze non-resolving cases to make sure that the world isn't full of patients who slipped between the cracks of ASAM's logic. And when we found high rates, we fixed that. We analyze the distribution of placements. If a lot of people are being recommended to hospital level of care, something might be wrong. So we're able to look at that and see, oh, people are misinterpreting all these medical questions. Let's put in some hints and error checking. So we've done that. We look at satisfaction, as I told you. We look at, we're starting to look at change over time. There's a co-triage, a continuum triage version. It's a short version of this that are used in some parts of the country for provisional recommendations as to where to go to get your continuum assessed. And when we have a patient who's seen within a few days, we want to see, did they go to the placement that was recommended for their assessment? And when they did the full continuum, did different information come through? So there's lots of different things we look at. And we're in the process of generating reports for health plans, states, counties, treatment systems, eventually even supervisors, so that you can use these data to continually improve your programs and the funding of care, so that treatment can become more effective and higher quality.
Thank you. The next question is, what is your experience using this tool as the comprehensive assessment?
Well, most of the places that use it as the comprehensive biopsychosocial. And that's the whole thing. Some parts of the country want a few additional items. Some programs want a specific inquiry about homelessness. Some programs want spirituality to be assessed a certain way. If it's a simple thing, you can actually put that in the comments section and just routinely add towards the end of the interview, or in the drug and alcohol section at the end, the comments section, you can type in a whole paragraph. You can type in pages. And you can say what the patient's connection to spirituality is and how does that affect their potential for recovery. We assess all of the elements in the book that are deemed important for placement and for initial treatment planning. But there may be some specific areas you want to document, and you could either add that in your own EHR, or you can add that as an additional comment. And if your system needed that statewide, we could even look at adding an item or two here and there.
Another question is, can the tool be used via phone?
Yes, people are starting to use it via phone, and they're indicating that, and the report states that, and the questions have instructions here and there where that's not as complete a source of data as eyeballing the patient. And so we take that into account, even in the scoring. Yeah.
Sorry, I'm scrolling through lots of questions. I just want to make sure I'm getting the right ones to you. I think some of them are going to be for FEI. So would the ASAM continuum ever be used with patients that do not have a history of drug or alcohol abuse?
So if the patient doesn't have that history and was referred or self-referred with questions about that, this is a very thorough way of establishing that, it's not a relevant concern. If there's suspicions or alternative data sources, collaterals who provided information, you're using all available sources of information. So you might find out from the spouse or from the PO that, this patient was arrested for drunk driving, but the patient says they never drink. So this will be an effective tool for really, digging into all the different aspects that you might want to inquire about. If it's a mental health patient who has no substance use history or concerns, it's not the ticket. Even though it has extensive psychological symptoms in its inventory, but it won't generate a diagnosis, and it won't generate psychiatric level of care per se, only the qualifier considerations in concert with the substance use needs. So it's really focused on substance use.
Thank you. And then just to clarify on the question, using the tool via phone, was that telehealth or telephonic?
No, we've had people who are starting to do phone interviews or, through the computer audio interviewing without the video, or actual audio video, seeing both, even FaceTime.
Great. Thank you so much, Dr. Gasron, for doing this. I'm going to hand it back over to Jill. There you go, Jill.
Yeah. Oh, can you hear me?
Yes.
Okay, thank you so much. Yes, thank you, Dr. Gasron, for going through the ASAM continuum. We only do have 4 minutes left. I know that there were many questions that came up on the chat, and Lauren has already put a document together. She's our expert at WebEx and all of the chats and getting those questions together. Thank you, Lauren. And so we actually have a list of the other questions. Many of those questions are related to, the core assessment, the integration into the EMR, some of the costs around that. So we actually have all of those questions from the chat today, and we will have some internal discussions so that we can follow back up and get those questions answered and back out to you. The intent would be that you would be doing, the ASAM continuum for those persons that do have an SUD diagnosis. The intent is also that we have one, comprehensive assessment, which the ASAM continuum, is a biopsychosocial assessment. I know some of you have asked that a few things be added to that, and to the continuum, what I heard Dr. Gasron talk about today is that they are willing to take a look at that if we would, make decisions about if homelessness need to be captured, cultural, information about people's spirituality. So what we will do is we've got all of the questions from the chat. Many of them are questions that Access will discuss and get answers to, and we can then get that information back out to the group. We may also then be, reconnecting back with Dr. Gasper and Bill and Sarah related to some, EHR types of issues, especially with FEI systems and with the EHR vendors in the state of Arizona, so we can get those questions answered. Is there anything else Dr. Salik or Lauren or anybody on the panel wanted to add? We just have 1 minute left. The other thing too is I know that this, as Lauren stated, this has been recorded and we will be able to put this up on our website. So thank you so much for everybody.
Oh, go ahead, Joe.
Oh, I was just going to say, thank you everybody for your participation today.